Hey everybody, welcome back. So we are now at the place that many of you have been waiting for. For those of you that want to become therapists and you're thinking specifically about clinical diagnostic assessment as it relates to mental illnesses or mental health conditions, this is what we're going to talk about. When we say clinical assessment, this is the category that this is the place we're in. So without further ado, let's jump in. Remember when I said at the very beginning that we're trying to accurately understand the problem so we can choose the right decisions or the right treatments? One of the ways that we can think about that is that if we make an adequate assessment based on real life symptoms, we can choose the right diagnosis and then develop a treatment plan that fits that diagnosis, okay? That's if we break that down to its kind of most simple, the simplest, most medical terminology that we possibly can. Because if someone comes in with a broken leg, maybe you remember this example, someone comes in with a broken leg and we ask them about their cough and we send them home with some NyQuil, we're missing the condition, but we're treating something that's completely wrong. So if somebody comes in and has bipolar 2 and we don't assess for the potential for mania and we just give them a depression assessment, we say, yeah, they're depressed. They look really depressed. We're making that error. We're essentially saying you have a broken leg, but we're treating only this part of it or something like that. And so that's why doing a holistic and thorough assessment is so important. Now, to give you a little bit of grace, that is a hard thing to diagnose. And especially if you are expected to do that within an hour, you miss those things, and people often do. And so developing good, thorough, systematic assessment processes that respect that things change over time, that's why this is so challenging but so important too. So that's what we're shooting for here. Now, there's just a few kind of random things to think about in terms of political issues when it comes to diagnosis. This stuff is really hard, not just to perform as a clinician, but also there's lots of change going on. So one of the things is licensure parity. I don't really want to go into this a whole ton, but in terms of like who can diagnose, there are some states in which mental health counselors cannot diagnose. New York is one of them. I think, actually, that's the only one that I know of. It might be others, but that's the only one that I know of. Because there's just politics involved. The psychologists have lots of political power, and they make laws in the state that say that other people can't do the kind of work that they're doing. And so that's really something that you'll either become involved in or become aware of maybe later on in your professional career. Once you have your clinical practices established and you kind of feel comfortable with your clients, you'll likely start thinking about the larger context of how does this work you'll get familiar with like billing practices, and you'll realize there's a lot of push and pull between the way providers interact with state laws and way practitioners interact with both of those things, and there's lots going on there. Licensure parity specifically refers to how people move certain licenses across states and how they equate from one place to the other. So if you're in New York, for example, and you move to Montana, all of a sudden you can diagnose, but if you haven't had practice doing that, not the greatest scenario, right? So if you go to New York from Montana, then all of a sudden you can't do the thing that you thought was an important and essential part of your job. So that's a political thing. Not much to say about it right now. Then, don't worry about it for now, but eventually you probably will. Competence in diagnosis. When we talked about level A, B, and C, we had this kind of discussion about can you perform certain kinds of assessments? Well, it's kind of like that. Can you diagnose certain kinds of things? Technically speaking, from a very technical standpoint, when you're done with this program and you're licensed as a mental health counselor, everything in the DSM is considered in scope. However, that's not entirely true because there are lots of neurological disorders that you have not been trained on in this program. I don't have the expertise to train you on them. So typically what we do is we refer out for neurological issues to a neurologist who can do different kinds of like brain things, right? Same thing with alcohol use disorders or substance use disorders in general, or potentially even addiction disorders in general. We can technically diagnose alcohol use disorder, but there are plenty of people who get licensed in substance use issues who say, no, that's our thing. You don't do that thing. That's our thing. We're specialized in it. And so whether you are or aren't is a challenging debate that you'll have with people, and you'll hear lots of different opinions on them. I'm not going to pick sides right now. I just want you to know that that's a conversation that you're going to have, okay? Or that you could potentially have later on. And you may have strong opinions about it, but I'm pretty willing to bet that your opinions are not as full and rich as they possibly could be. Part of the reason I believe that is because these are big and complicated issues, and unless you've been in the field for a long time, you may not be considering some of the important dynamics that are happening between state policy in any particular area, the clinicians, and you're in that specific state too, because it's different in Montana. I'm still learning about kind of the balances between what SUD or substance use disorder counselors or addiction counselors, what they do versus mental health counselors, and it's messy. And then lastly, I kind of already alluded to this, but power struggles between licensed psychologists, CLCP. I don't know why that says that, but it should be like LCPC, or there's different acronyms for licensed counselor. By the way, if you're not familiar with this, some states call it a licensed professional counselor, LPC. Some of them call them licensed professional clinical counselors, LPCC. In Montana, they're called LCPC. I think I was trying to say that here, but I just messed up the acronym. There's just lots of different titles. But the point is that there's just power struggles between social workers can't do this because they're not trained well enough and they're out of the side of their lane. And marriage and family therapists, that's what MFT means. They don't do this kind of thing. They do the other thing. And there's just a whole bunch of that kind of stuff. I will tell you my opinion here is that by and large, most of us cover under this umbrella of mental health counseling stuff, or mental health, mental illness treatment, we'll say that. Think of it like a bunch of Venn diagrams, and there's so much of those Venn diagrams of what we all do together. So much of that overlaps, and yes, each of us has our little niche and our unique parts to what our profession does and how it differentiates from others. But the great majority of what we do together is trying to do the same exact thing, is to help clients to understand conditions, to diagnose accurately, to provide adequate and effective treatments. And by and large, we do a lot of those things in a very similar way. But there are plenty of people, and they're oftentimes the very loudest voices, who are like, no, we're different and unique and special, and we should get this kind of funding, and you shouldn't, and we're better and you're worse. And it's exhausting. And I even get exhausted just talking about this. There's so much more that we can collaborate on and work together on. Montana actually does a really good job of providers working together compared to other places that I know of. I work with a lady who's in California, and she's like, oh, it is such a mess. There's so much infighting amongst counselors, between counselors and social workers and psychologists, and it just gets really messy, which makes your job of learning so much harder. But be aware of it, but we're not going to focus on it right now. So again, reorient. The fundamentals of clinical assessment is determining the need for further testing. We've talked about this slightly, and I'll continue to say this over and over again. When you hear of a new client who's coming over who called in over the phone, and they're going to come in for your first meeting, you haven't met with them yet, you have a little bit of information, and that information tells you something about what else do I need to know. They said they've been feeling sad about their job. Well, sad leads me to believe that I need to test for something like depression, test for things like interpersonal issues, test for things like career dysfunctions or something like that. There's all kinds of possibilities, but that just means I need more information. Even after that first session, there might be something else in your head that says, I don't feel like I have the full story. So what else is there? Should I use a specific tool that could help me get that other thing? That's part of our process of what we're learning here. And also what you'll continue to learn for years beyond this. In terms of assessment in the DSM-5, this is one thing that I've experienced students say, and something that you guys go through. Sometimes we hear of testing and we're like, do all tests lead to a clinical diagnosis? Well, even something like the GAD-7 or the BDI-2, those ones, although they can contribute to making a diagnosis, they don't specifically pair exactly with the DSM. However, when we do the CAPS-5 PTSD assessment, That one specifically follows the DSM-5 criteria, and you can see how it does that. I showed you that last week. So you can see exactly how those criteria are paired with the DSM. So some of them make that diagnostic process really easy, and others do not at all, especially if they're made by like researchers to understand a concept, but they don't necessarily do clinical diagnostic. They're trying to understand a new thing. So it makes this clinical assessment process more challenging, and that's why we say, does the knowledge we have here, even if it's even if it tells us other things that are seemingly unrelated, does that provide evidence for a diagnosis or clinical diagnostics, something like that? So that's going to be a challenge. We're going to navigate that as we go through here. When I say here that you need to know the DSM-5 and ecological factors beyond behavioral symptoms, what I mean by ecological factors is that's a specific term that gets used in counseling, and you'll probably want to know this. If we don't cover it in the program, we should. But if you've never heard it before, there's a guy named, last name Bronfenbrenner, and he has this model of what's going on within a person in their culture. He has got different words for this, but their like family sphere, their community sphere, their national sphere, their global identity sphere, their spiritual sphere, and he's got all these different spheres of like what makes up who we are. He calls it the ecological model, and it actually goes by like microsphere, mesosphere, macrosphere, a whole bunch of other stuff. But it's more complicated, but really helpful to be learning. So if we're not covering it, we totally should. But anyway, ecological factors means the DSM focuses on behavioral and symptomatic behaviors and experiences. But when you're making a full diagnosis, you need to know things about family dynamics and educational background and you know, sort of the other context outside of that stuff that can contribute to the certain diagnostic impression. That stuff's important, but it doesn't get covered necessarily in the DSM, even though the DSM will say, like, please consider all that other stuff, but that's just a different task. When we talked about assessment results and communicating those last week, that's another part of that process of communicating not just physical symptoms or mental health symptoms, but also how do those show up in a person's life in a meaningful way. So we'll just leave it there in terms of like fundamentals here, but there's so much more to talk about there. DSM-5 and the ICD-11. So the DSM is the Diagnostic and Statistical Manual for Mental Disorders in this 5th edition. Okay, it's put out by the American Psychiatric Association, and that's the key word there is American. So it's an American standard for what mental health conditions are. It's not a Chinese standard. It's not the Canadian standard. It's the American standard, okay? So that's what you're going to use in 99% of your practice settings that you're going to go into. However, lots of medical doctors, because the practice of medicine happens more on a global scale, and if I had a crystal ball, I would foreshadow that the mental health world within the next, I don't even want to put a timeline on it, but 50 years, maybe 50, 100 years, is probably going to do the same thing, which is the DSM is going to be a diagnostic standard worldwide with more and more understanding of cultural nuance that's involved in that. But as it stands now, the DSM is an American thing. That's what most of you guys are going to use. However, in some settings, you might also use ICD-11 codes. And what that means is if you look in the DSM, there's always a code. You'll learn this in your DSM class. There's always a code from the DSM that you use, and that's used for billing and coding purposes. The ICD-11 sometimes has matching codes, and that's a whole different part of the mental health world that we're not going to get into very much right now. But it's important to know that ICD-11 stands for the International Classification of Disease in its 11th edition. And the key word there is international classification of disease. So it includes not only mental health conditions, but physical conditions as well. Now, the one thing to know about those two it's helpful to know about those two. It's not necessary. But there's different things in the DSM than there are in the ICD-10. In fact, the ICD-10 has sort of like it'll lump things together in a way that is useful for global assessment of conditions, in a way that the DSM gives more nuance to, and it explains things in a deeper context. So you're going to focus on the DSM. Don't worry too much about the ICD-11, but you'll hear about it. In fact, you'll hear probably more about the ICD-10 because people are still kind of transitioning over. But even though it's been a few years, it just takes a long time for that stuff to happen. Pros and cons of clinical assessment. Now, we've already talked about we've had discussions about like whether assessment's a good thing or does it label and stigmatize and all that kind of stuff. That's part of what we're talking about here. But we're going to get in a little bit more detail. One of the things that happened with the DSM-5 as it came out of the DSM-4 is that there are some situations in where mild severity indexes showed up, and it encouraged pathologizing of common phenomena. Here's what I mean by that. There's a certain level of severity. When we talk about diagnosis, we're talking about two things. We're talking about the severity of the symptoms and the duration. How long do they last, and how bad are they? In other words, they have to have been present for more than a certain time period to show that it's been ongoing. It's not just something that happened yesterday and all of a sudden we should have a diagnosis, because it needs to have like some stability to the patterns of symptoms, if that makes sense. If you just say, oh, I gained a bunch of weight, or I've been kind of feeling hopeless, if you're like, well, it started this morning, and you're like, okay, well, let's give it a little bit of time before we call it this like chronic condition, right? It's not a major depressive disorder until it's been majorly happening for a while, something like that. So I think you guys get the point. If it's not severe enough, then we don't want to call it a condition, right? It's like if you have a scratchy throat, it's not really intruding in your life and causing functional limitations, so we're not going to call it a cold. But once it reaches a certain level of impairment, then we could say, oh yeah, this is a clinical condition and you need to stay home from work to recover from this. Same thing here. When we take that standard and we say you have to meet these certain criteria in order for it to be a thing, if we lower that, it means that more people count as being depressed or having autism or something like that. There's different conditions in which this has happened. But if you lower that standard, lower the bar, it means more people are going to meet that criteria. And the problem is that then you'll have people running around saying things like, and you'll all have heard this, like, oh, I'm so OCD about that thing. And you're like, no, OCD is a clinical condition. And in order to be considered to have obsessive compulsive disorder, it's not just you get weird about like washing your hands or something. In fact, normal hand washing requires more hand washing than probably even I do. I do wash my hands, just for the record. But I don't wash them as much as my wife. And yet she's even still not obsessive compulsive, right? So like she's just more careful or risk averse or something like that I am. So what happens if you lower those standards? It can encourage pathologizing of things like washing your hands, of doing things repetitively. And we don't necessarily want people going around saying like, oh my gosh, I'm so OCD, or I have so much anxiety or whatever, because it creates, what does it create? It creates encouraging people to identify with problematic conditions, something like that. And there's probably a whole bunch of other things we could explain too. I'm sure some of you could say this better than I'm saying it right now, but anyway, that's a thing, okay? The use of adjustment disorders or blanket diagnoses that reduce the clarity of the diagnosis. So you'll hear a lot of theorists say things disparagingly about the diagnostic process. Part of the reason for that is that diagnosis is essentially a medical process. We, as medical providers, part of us says that we want to be able to explain the symptoms and the symptom cluster and how that relates to a diagnostic, meets diagnostic criteria and it's an actual clinical condition, because then we can very systematically say, well, here are the treatments for it. It helps with billing, it helps with coding, it helps with funding, it helps with providing large-scale interventions. However, with that being said, providing therapeutic interventions sometimes is directly contradictory to that medical process. And I don't want to get too far into this because we'll talk about it in different classes. But there's these two things called the medical model and the social model. There's other models, but the medical model says there's a problem within people, and like a virus, if I go in and I kill the virus, then the person will become whole and healthy again. However, as we think about disability or mental health conditions, the social model says the problem is not necessarily within the individual, but the problem is the society itself, or the system, or the process, or something like that. So the person is not sick. They're just showing symptoms because they're impoverished by an economic system that doesn't work or disadvantages people. That's just one example. So when we talk about things like, where are we? Adjustment disorders. Let me walk this back. When we're talking about things like that, some people strongly avoid the DSM because it overly medicalizes people. And so what happens, here I am trying to pull this all back. What happens is people say, I don't want to give somebody a diagnosis of major depressive disorder or borderline personality disorder or bipolar 2 because those have social consequences, or they are directly contradictory to the therapeutic process. I want people to become whole and feel positive and feel like they have potential for health and life, and giving them a label or a title goes against that whole philosophy. And so instead of saying this person actually has bipolar 2 disorder, sometimes people will say, I don't really care what people have. I'm just going to not go there in that whole medical diagnostic process. I'm just going to say, just call it an adjustment disorder and move on. Or, and so that's the thing that happens. Or another thing that happens is if people don't get good at doing assessment, or they don't fully appreciate the process of digging deep and really finding out what is going on with this person, they can miss things, and they'll say, I'm treating couples for relationship conflict, and they don't really meet clinical depression standards, but in order to get paid, I have to give them a DSM code, so I'm just going to call it an adjustment disorder. They're just adjusting to married life. Neither one of them is depressed or anxious or whatever. They just have an adjustment disorder. And so lots of practitioners, sometimes for good reasons, really good reasons, I mean that seriously, and sometimes for really lazy and bad reasons, they just classify too many things as adjustment disorders and don't really care enough about the diagnostic process. Now, when I say there's good reasons, part of it is that the insurance companies, they do not appreciate saying somebody should get services for marital discord. They're like, that's not a thing, right? Even though we all know that marriages are hard and there are problems throughout that sometimes we need guidance through. But the medical world and the insurance world, they don't acknowledge that. Same thing with rehabilitation counseling. We as rehab counselors, we can know very deeply within our professional expertise that career support is an important part for most of us across our lifespan. At some point, just about all of us, especially people with disabilities, need support and help through the vocational process. But for billing and coding and insurance purposes, they don't necessarily see that as significant enough to be worth treatment because they don't want to pay for it. And it's not to say that they're doing something wrong. It's not to say they're the bad guy. There's very good reasons for this. But nevertheless, the process is just kind of clunky and weird. And so we overuse things like adjustment disorder to then get billing or get paid, essentially, to use that for billing purposes. So there's a whole lot to say about that, and we could talk about that in more detail, but that's just a thing that happens. So one thing I encourage you guys to do is practice the assessment process, get good at it, understand it, learn it, and then you can learn the exceptions to it later, but you'll hear people talk in both ways. We need to use diagnostics more, and we need to get better at our medical process. And other people will be like, no, don't waste your time on that. We need to get better at being therapeutically effective. And both are probably true, but in a complex world, probably none of us can do all of that at once. So it's a challenging thing. Okay, another con about clinical diagnostics, is emphasizing pathology. One of my favorite quotes, you may have heard me say this before, is from Albert Ellis. I'm pretty sure that was him. He said something about the DSM, and he called it the big book of unhappiness. Because there's nothing good that comes out of it. There's nothing in there that says, yeah, but people are really pretty strong. People are really pretty good at stuff. This is what good, healthy relationships look like. This is what a good, healthy person looks like. No, the whole point is to identify things that are not going well, things that hurt, things that are painful. So, because as part of that medical model, it's okay if we identify what doesn't work, then we can treat that thing. That's the whole goal of it. So there's an overemphasis on pathology. Another part that we've talked about briefly in this class, and you'll talk about more in other contexts, is stigma. And stigma comes from things like diagnosis. If you give it a label, that means that you can use that label to deny people certain kinds of things. And there's not only can, this is kind of skipping down to the pros section, but not only can diagnosis be used for really good things, it can give people access to certain treatments, to certain medicines, to certain therapeutic techniques, to certain funding sources. Those are all great things. But on the flip side, it can be used to stigmatize, label, pigeonhole, and do all kinds of nasty things for people too. So it kind of fits into both categories there. But so again, lots more to say, I suppose. I've already explained the medical versus social model, so I'll skip over that one. We've talked about labeling briefly, so let's skip over to the pros. One of the major reasons for using something like the DSM and all the ways that I've been talking about so far are, some of them fit into like, yeah, it's a good, important thing, but a lot of them are like, this is a big problem. There's like a bunch of stuff that doesn't really work about this, and it's messy, and it's difficult, and it's challenging. So why do we even go through all this trouble? Well, one of the reasons is it gives us as counselors common language to talk about mental conditions. Because it's one thing for me to say, oh, you just have a relationship. Honey, you're just going through some stuff right now. You're going through a phase in your life. Like, I could say those things, right? It's just part of your journey. Everybody has problems in life. We can say those things, and those are fine things to say. But someone across town will be like, it's just part of the process of life. Just buck up and get over it. Those are whole different ways of engaging in the therapeutic process. And that sends a really different message to people. One of them says, there's a real thing going on here. Another one says, hey, it's just get over it. It's not a real big deal. You're just making a big deal out of it. So you can kind of get the impression of mixed messages. Having the DSM gives us consistent common language that has a standard to it. And it's so helpful in terms of being able to make professional progress. By professional progress, I mean for the field of counseling to really say, here is what we're treating, here's how we're doing it, and here's how we use common terms so that if I say hopelessness in one area, ideally we'd be able to identify hopelessness in a different state or different country or something like that. So giving us common language is so helpful. I mentioned it legitimizes conditions already, so there's not much more that I want to say about that. Earlier when I was saying that making a diagnosis has to do with severity and duration, how bad is it and how long has it lasted, severity indexes really give us a good, helpful way of explaining what's the likely dose of treatment. I guess both of those things do. Severity and duration probably both contribute to this. But they assist us in saying, well, a person with really significant and serious depression might need a higher dose or more time in counseling than a person who's experiencing mild depression. If I come in just for like a depressive episode that's probably diagnosed as an adjustment disorder because it doesn't meet clinical criteria for major depressive disorder, but it's like somebody's sad and hopeless and feeling suicidal, but is not all of the things that make up a diagnosis, that could maybe be helped in a few sessions or sort of situationally through life, as opposed to ongoing and consistent need for therapy for years sometimes. And so it can assist in conceptualizing what is treatment actually going to look like. Do you need medicine for a little while, or are you likely going to have to be on medicine for the rest of your life? And substitute the word counseling for medicine in any of those contexts. Okay. Now, we've already talked about this a little bit, so I'm not going to dig too deep into it, but as we discussed structured interviews, semi-structured interviews, and unstructured, there are plenty of structured interviews that you can use. Like you can read through, here's some for just different names of structured interviews, sorry. If you want to have that kind of structure to it, some cases are really important and helpful to have that. Especially if you're working in other medical environments where that information is necessary. If you're needing to justify for billing purposes or something like that, if you're doing research, those are really important to have structured interviews. If you're working in forensic contexts where they need a validated assessment process, those can be helpful too. Here's some examples for different kinds. The CAPS 5 that we're using in class, That's considered a semi-structured interview. However, you could use that as a structured interview if you read down through it sort of systematically from top to bottom. It's not really designed to be that way, so I wouldn't necessarily call it that. But when it gives you the prompt and you just follow it word for word and don't deviate, that's essentially using it as a structured interview. So some important context to have those. Other times you wouldn't want to use them, but you get to learn that later. In terms of using, having a semi-structured interview, especially when you're learning and you're practicing, sometimes it can be helpful to have those, but then just deviate from them to sort of put your own spin on it. Sometimes that's appropriate. So talk to your supervisors later on about how that happens if that's something you want to do. I'll skip over number 2 because I guess what I'm saying is there's lots of interview processes that I'm not familiar with. So lots of ways to do that. As far as the unstructured interviews, you're going to get a bunch of practice in this when you get to practicum and internship and beyond. When somebody sits you in front of a client and says, okay, go. And you look around the room and you're like, okay, what's going on? What can I help you with? And they just start talking. And you're like, I just let them go and hope they talk enough for you to get through the first hour of your first client. That's considered an unstructured interview. And over time, as you get more experience, you're going to learn about, I can let the client talk about what they want, but I can also help them navigate to the important things that I need to know. And also, I can help structure the first interview in a way that helps me get the information that I need to make a diagnosis, to help develop a treatment plan, to help establish goals. But I can let them do it by doing it in their own way. That comes with experience. So in the very beginning, lots of you want structure, and we're like, yeah, but it's really hard to do and it's very limiting. And that's just the balance that we have to walk. Oftentimes what we do is a program, and lots of counseling programs do this, and supervisors out there as well, they'll say, well, you've got to get used to this unstructured process and all the gray areas. So we're just going to jump right into it, throw you right out of the frying pan into the fire, as the saying goes. And that's super anxiety provoking for some of you. However, it's also very realistic as to what it's going to be like when you're doing counseling down the road. Hopefully there's a balance in there we can set. And throughout this class, I've tried to give you really structured things to begin with. Then there's the CAPS 5, which is sort of semi-structured. The final project is like, okay, go sit with the client and figure it out. And that's harder, right? So I'm kind of walking you through this process in sort of a micro way through the class. But anyway, enough to be said about that. So how do you know what tools are useful? We're talking about these in class 2. But here are some things to consider. It depends on what conditions you need support and understanding. I've mentioned this many times in these lectures. And I've said, if somebody comes in and says, I am experiencing career dissatisfaction, do you then pick the Beck's Depression Inventory? Is that appropriate? No, it's not really appropriate. They just want a new career that brings them meaningful joy in their life, They're not necessarily saying I'm depressed. So you don't want to use the same tools for every single client. But what else do I need more information on? Somebody comes in and says, I'm not doing well in school and it's pissing me off. You might check for depression, but if you find out like they're not depressed, they're just angry, they don't meet clinical criteria for depression, but we might want to check out like the potential for ADHD or learning disorders. So I'm going to make a referral out because I need support in understanding that thing, right? So that's what we're talking about here. Excuse me. For a broad or narrow focus from general conditions or specific diagnosis, I don't know if I've said this in these lectures or if I've just mentioned it in class, because I say this every semester, but I forget if I've already mentioned it or not. But one of the things we're, excuse me, having a little issue. One of the things we're doing is, as counselors, we want to understand mental health conditions, right? And we assume that everybody coming in through the door has the potential for one of those because that's what they're there to do. That's what they kind of expect from us, is to help understand those things. But we have this big umbrella, and then we're trying to understand, okay, if they say the words like sad or anxious, that kind of splits up. we know to focus on these things, not those things. And as we focus a little further, we want to know, are they dysthymic or do they have major depressive disorder? Those are two different things. Or are they just experiencing like relationship conflict or adjustment disorder? So then we break it down even further. So there's this like flow chart, if you can imagine this. And we're narrowing and focusing. Part of having tools is that if we have a tool at our disposal, we can help narrow down and focus down as fast as possible to figure out what at its core is really going on here. What's the underlying issue? So when I say from broad to narrow, that's what I'm talking about here. And you can see page 348 for more information, but I did not look at page 348 before I started recording this to see what is exactly there. So look it up and we'll talk about it in class. How about that? Much of this section of the book describes just a few of these tools. Okay, so in the chapter on clinical diagnosis, there's a bunch of tools here. One of the things you should know about and you should get practice in is using a symptom checklist. Now we're kind of doing that in very more specific ways, like the symptoms of depression with the Becks, the symptoms of anxiety with the GAD-7, the symptoms of PTSD with the CAPS. We're doing that on a diagnostic basis. But there are tools like the SCL-90, which say, based on all of those symptomatic criteria of anything that could possibly happen, let's use this overall symptom. It's a 90-question evaluation to find out, like, how do we narrow down that process a little faster by symptom cluster? Excuse me. Another one we'll talk about in a little bit is the cross-cutting measures in the back of the DSM. Level 1 cross-cutting measures is basically, let's kind of cast a wide net and understand what potential symptoms conditions could we be dealing with based on symptom presentation. And then based on that, we can go down to level 2 to sort of break it down a little bit more. That's kind of what we're talking about here. So lots of tools here, lots of different ways you can do this. You can see like we're using the CAPS in class, and I mentioned in class that the CAPS is not necessarily the easiest one. It's actually kind of challenging, but I chose it for very specific training purposes. But there's another post-traumatic stress diagnostic scale that you can use. The EDI-3 is one they have in the book. The SASI is more related to substance use, but it also includes potential for like legal impact, and there's some validity scales in there too that can be helpful. So that's on its 4th edition now, actually. So the SASI 4. The suicide risk assessments, those are ones that we haven't covered yet, but maybe we'll do it this week. Maybe we'll do it another week. I'm not sure, but we need to cover that. One that there's a list of them in the textbook. The one that I'm the most familiar with and is pretty much universal and gets used a ton is the Columbia. You'll have access to this in the course, and we'll go through it slightly. Maybe we'll do that this week in class, or I'll put up a separate video about that one. But suicide risk assessments are absolutely essential, and there's just more and more emphasis being put on them, especially in places Montana, which I just heard I think has the 3rd highest suicide rate in the country, and that's saying a lot. So a lot to be covered there. If you don't feel comfortable, if you're going to go into being a therapist and you don't feel comfortable doing a suicide risk assessment, that should be one of the first things you do when you get out. And in fact, I think the state requires that you have special training in it, and it's assumed that you have it in school. But we will give you some training, but if you don't get enough of it here, please go out and do that as one of the first things you do when you get out of school and say, or even while you're in school, get comfortable with it, because it's literally a life or death thing. And I don't know why we don't spend more energy and effort on that. But learning depression is something that you need to do with foundational, and it's basic and it's easier. Suicide risk assessment is challenging. It can be difficult. There's a lot to know about it. So developmentally, it's, we don't cover it as much, maybe because it's sort of harder and more challenging, but it's also one of the most important because there's life or death on the line. So get good at that, practice it, and we'll do some talking about it too in class. Okay, the DSM cross-cutting measures. They're on the back of the DSM. I forget the page number now, but we'll cover this in class. And I think I have a special video about this. Maybe I don't, but I'm going to show you this right now, actually. Let's pull this up. Actually, no, I'm not, because I don't want to lose the captions at the top. For those of you that are in the program, if I don't show these to you, I'll show them in class and we'll walk through them specifically. If I don't make a special video, feel free to tell me like, hey, you said you were going to explain this. Please do, because I need to know. But it's in the DSM. If we don't get it in this class, you're absolutely certainly going to get it in another class. So it'll come. If you don't get exposed to it now, you'll get exposed to it later. But basically, I already explained what those are. It's just a way to sort of filter down from symptom to specific conditions so you can kind of figure out how do we make a diagnosis here. And then I'll skip the last part because I think I've talked about that enough in different contexts throughout the class. Okay, one of the things that you do need practice in and that you need to really need to understand is the mini mental status exam. One of the things you also need to understand about it is that lots of people do it. Lots of people do it in different ways, and there's lots of different opinions about what makes the right kind of mini mental status exam. Like, what do you have to include in it? This list here is a general list. Okay, so before I get into this general list, what does it mean? Let me explain what the MMSE is. Sometimes you'll hear about them like MSE. I heard like MSI the other day, like mini mental status inquiry or something like that. I don't know what it stands for exactly, but I heard something weird. But because a lot of people are doing this in a lot of different ways, what it basically is it's a snapshot, a quick behavioral observation, not just behavioral, but a quick observation about how is a client presenting in a way that's fast and efficient, okay? Oftentimes you'll see this, like psychiatrists will make their rounds in an inpatient unit and they have 15 minutes to spend with the client. And so they say, how does the client appear? They appear unkempt and disheveled, which then tells you a little bit of information about, like, what's their symptom presentation? Well, refusing hygiene is part of a diagnosis of depression, right? So it gives you a little bit of that kind of information. What is their psychomotor activity like? Client is fidgeting a lot. Excuse me, I'm having some struggles here talking. I've been talking for a couple hours now, probably too much. The client is fidgeting. They're constantly biting their fingernails and they're touching their face, and or they're like shaking their head, or they're sometimes with like certain medication after effects. There's a thing called tardive dyskinesia that comes from heavy antipsychotics, specifically like first generation antipsychotics, the things we used back in the 50s for like in mental institutions for serious and significant issues, that we're not using those necessarily anymore, but they have side effects. So one of the side effects might be tardive dyskinesia, which is just like automatic muscle movements that a client is not aware of, but they're still happening. So that says a little bit about, how is a client presenting in terms of just nail biting and fidgety movements. That just might indicate anxiety, basic anxiety. So those are examples of how to what those things mean. Attitude toward examiner, something like that would be a client, and you can use quotes if you need to here. Client told examiner to F off and appears resistant to treatment, right? Like that's an example of attitude towards examiner. Or compliant, respectful. Those are also sort of on the other side of the spectrum. Attitude towards examiner, curious, interested, respectful, all those kind of things are totally appropriate. As far as affect and mood, client's affect was blank and flat, sort of just like not expressive. Or client was flamboyant and very expressive. One would indicate maybe a mood disorder like depression. Another might indicate a disorder like mania, or might just be like, normal affect and mood appropriate for circumstances, something like that. Those are appropriate terms. Speech, there's, I'm going to kind of fly through these, not give these all examples, but speech, fast or slow, something like that. Perceptual disturbances might be used for something like if someone's experiencing auditory or visual hallucinations, that might be an example there. Thought, there's lots of words to describe disoriented, dislocated, sequential. Some of these are positive, some of these are negative words. Orientation, what you'll see often there is orientation times 3 or orientation times 4 or orientation 3x. What that means is a person is oriented to themselves. They know who they are, and they know that their name, and they have a sense of identity and presence about them. If somebody's experiencing dissociation or depersonalization, they would not be oriented to self because they feel like they're having an out-of-body experience, or they feel like they are just not themselves today or something like that. So that's one kind of orientation. Orientation to time. I know what year it is. I know what time it is. I know that it's daytime or nighttime, something like that. Not everybody does know that. Orientation to place. So self, time, place. So I know that I'm in Montana right now and I'm in the school. Sometimes people, if they're institutionalized, they might be like, I'm at home. I know I'm still with my grandma or something like that. So that's what people mean when they say orientation times 3. Sometimes people say orientation times 4, and usually I remember what that fourth one is, but I'm forgetting it now. You can Google it if you need to. How is a person's memory? Are they having short-term or long-term memory conditions consistent with, normal memory within normal range, or experiencing something like amnesia or some other neurological dysfunction, something like that. And then lastly, concentration or attention. If somebody has ADD and have split attention or having attentional difficulties, like not being able to focus on the interview or something like that. So all of those things are just general categories. Now, here's the thing to know, another thing to know about a mini mental status exam. There are so many different ways to look at this, and more specifically, so many different words to describe these things. So oftentimes, when you're practicing a mini mental status exam, what you're really trying to do is just expand your vocabulary in terms of how do you describe these kinds of things. And there's lots of different ways to do that. So what you'll see in the course portal is you'll see different examples that I pulled in from different specialties and different kinds of mental health practice areas where people will use different kinds of terminology. Now, oftentimes what you'll get is you'll get people who are psychiatrists who have been doing these for a long time, who use a lot of Latin phrases, who use terminology that's more medically focused. And so you'll see lots of words that you don't know and you don't understand. Like just one that's pretty common across fields of mental health is a person's affect or mood is labile. And what they mean by labile is mood fluctuates drastically from one emotion or mood state to another one. Normally, it's pretty common for us to be like, if we're angry, our anger lasts for a while and it subsides over the course of maybe like minutes or hours or days even sometimes. Maybe not days, but moods can last for a while, right? But if somebody goes from like, oh, you are my favorite person in the world, I absolutely love you, and you say like, oh, well, okay, let me ask you another question. Do you like my shoes today? You're like, no, I friggin' hate your shoes. I think you're stupid. I hate you and I hate this whole place. Like you go from like, you're my best friend to my worst enemy really fast. That's lability. And that's just a kind of cheesy example, but the word labile is not something that we typically use in our normal parlance, right? Like as counselors, we're not walking around being like, oh, she's so labile today. Like, no, she's moody, and she fluctuated really fast, moved from one mood to another. That was strange. What does that mean for us in our work together or whatever? So oftentimes this is an exercise in expanding your vocabulary, okay? So what we go through in class is you're going to see a bunch of different examples. I'm not going to go through those now, but there's a bunch of different PowerPoints and PDF, just lists of words that fit into these categories or categories like them. Now, ideally, the categories would be consistent and similar. There are some dissimilarities you'll see in different places, but the whole point of this is that you can adapt it to fit your needs. And the categories can change slightly if you need them to. The words you choose to use and the words you learn to use. The big thing I'll say about that is the more you learn to use words that sound professional, that are very descriptive and precise and concise about what condition is going on, the better off you'll be. Now, does that mean you use fancy words? In some cases, yes. Use the words that are going to match your audience. We talked about this last week. If you're in a medical facility where you're providing consistent, coordinated, and integrated care with a bunch of other medical doctors, then you may want to practice more of like speaking their language. If this is just something you're doing for clients, they oftentimes don't care about this stuff quite as much. And so using words that they're going to understand, that matters. Get smart, use it appropriately in your setting. And it's hard for me to tell you right now what that appropriateness is. but there's lots of examples that we'll show in the class lecture. And if you're not watching that, then you'll get to see them in D2L. If you're watching this outside of the school context, just because this is on YouTube or something, then just do a Google search for mini mental status exam, and you'll find a whole ton of vocabulary that might be appropriate for your uses. Likely you'll find so much that you'll get overwhelmed and you're not sure what's appropriate, in which case just start learning, just start figuring out, ask around, talk to people, and say, how is this useful? Do we even need this? That kind of stuff. How are we doing on time? Okay, this is the last slide. Good. Oh wait, one other thing I want to tell you here. When you're, wait, no, I just lost my train of thought. Okay, we'll skip over to this one. If it comes back to me, I'll tell you. Just had a brain fart. How's my memory and concentration? Poor, not good. Just kidding. Sometimes you'll hear the terms, when we talk about assessment, and then we talk about all the political controversy in our first slide, we talked about that. We'll hear terms like a psychological assessment, a psych eval, a neuropsych eval, and sometimes those words get muddled together, or we just don't know what the distinction is. So I'm going to break that down just a little bit for us here. A counseling assessment usually is done for the purposes of therapeutic treatment or diagnostic explanation. So how do we do our work within the bounds of what we do? We do a counseling assessment. If we're doing a psych eval, oftentimes a psych eval means a very specific thing, and they're usually done by a psychologist, and they use more complicated and challenging and difficult tools, ones that we typically don't use. So for example, a psych eval is going to use a bunch of intelligence tests, and it helps identify things in a very much more nuanced way, like ADHD, learning disabilities. Trying to think of other ones off the top of my head, but like those are pretty common ones. Autism spectrum disorders, that kind of stuff. They might be using things like the MMPI for pathology, understanding pathology. But a person with a learning disorder doesn't necessarily have a mental health pathological condition in the same context, right? Even though they might fall under something that's diagnosable in the DSM, they're different kinds of things. And so it's usually more complicated tools and a longer process to help understand something that needs a lot more understanding of the nuance, something like that. But a psych eval isn't necessarily going to go understand things about the neurology or the things going on inside the brain. Some of it they are. Like, for example, how does the brain use its memory? How does the brain use its spatial recognition or spatial orientation? How is it using its ability to concentrate on sustained things? Its ability to collect and retain knowledge over time? Those are things that a psych eval will do. However, a neuropsychological assessment is often more focused on neurological conditions. Now, those terms can kind of be used interchangeably sometimes, it depends. But the reason I'm telling you all this, and then I'll talk about the slide here, is that people will say counselors don't do a psych eval or a neuropsych eval, and most of the time that's true because we're usually not trained or qualified to use level C assessments, or our treatment depends on things like understanding depression, anxiety, interpersonal issues, career-related issues, social and systematic societal issues, environmental, ecological kinds of things. That's kind of in the wheelhouse of what counselors are specialists in. Whereas psychologists and neurologists often focus on different things, especially given their background training. So a neuropsych eval, I already mentioned, often uses the level C assessments. Without supervision, you don't want to do those kind of things. Now, I remembered the thing that I had the brain fart earlier about when I was going back here, and I'll mention it now. Sometimes you'll find something like a mini mental status exam that asks you to like draw out things, and there's even, as part of the program here, one of the other professors asks you to do one of these things. You want to draw a shape, and there are certain neurological conditions where a person can only draw half of a shape, or you ask them to draw a square and they draw a circle and they see nothing wrong with that. Those are kind of things that are more useful for a neurological exam. And so my advice is that they're really not that useful. However, the reason that they're taught here, and the reason some of you might get exposed to that, is because you want to rule out those neurological issues to make sure there's not something like that going on. Because if there is something like that going on, that's when you need to send somebody over and refer them for a more in-depth neurological evaluation. Excuse me. So there is rationale for using that kind of stuff. The reason I don't use them is because it doesn't really help us do a mini mental status exam in a way that collects and uses the vocabulary and collects the information that we use for our purposes. So there's rationale to rule something out, and there's rationale to not use it because we want to find more information about this other thing. You guys get to make those choices, and I'll help you make them too in your specific circumstances. But if you find that there's something else going on that you're not qualified to handle, like maybe a neurological issue, and those are important, and if you don't check for them, you're not going to know, that's when you can ask for some help with a neuropsych eval like this, or a neuropsych assessment. So what else do I want to say about this? Number 2 there says they often consist of a battery of tests, and a battery is a specific term that just means a bunch of tests put together. They might use an achievement test, an intelligence test, and I don't know, a couple different kinds of ADHD assessments or learning disability assessments, or just like a bunch of stuff. But you put them all together and you say these 3 together really help with understanding autism, and this different bunch of tests really help with understanding learning disabilities or something like that. That's what a battery means. It's just a group of tests. So what's the purpose? Why would you do that? I've already kind of explained that it catches things that we just don't typically treat or focus on as counselors. But remember, there's so much more context. When we're talking about clinical assessment, oftentimes we're focusing on diagnosis within the DSM, but we want to rule out that there's anything like biological going on. Why would we use that version of the MMSE? Because there might be something neurological or biological. It might be an electrical imbalance or a chemical imbalance in neurotransmitters, in which case we need medicine, not talk therapy. So it's just trying to grasp a bigger picture of biological, electrical, chemical, physiological things going on as the root cause. Because if we assume that as therapists we can help every mental health or every mental disorder without the help of medicines, without the help of physical and exercise changes, which a physical therapist can help with that kind of stuff because the person's experiencing pain. A lot of anger comes out of physical pain. A lot of depression and sadness and hopelessness comes out of being physically in pain. So we want to catch that. We want to try and cast the widest net, excuse me, and have the biggest scope of that ecological understanding of the biggest net. So hopefully that makes sense. I think you guys probably get it, and if you don't, you're just like, you've been talking for an hour, I'm so sick of listening to you, I just want to get this over with. Then I'll just be done. Hopefully it makes sense. If it doesn't, ask questions and I'll give more explanation. But maybe I'll say this to try one more time. We need neurologists, we need psychologists, we need physical therapists and occupational therapists, and we need medical doctors and psychiatrists. And we need those people because they can do things we can't do. However, it's important to understand that we can do things that they can't do. So as I said in the beginning, there's political issues all over the place, and largely we're doing the same things. However, we have a better understanding at things like interpersonal dysfunctions and attachment relationships and things like that psychiatrists and medical doctors may just not be trained on specifically. So learn about those things as you go on, especially in terms of how they relate to clinical assessment. What do we know that other people don't? What's our specialty niche in terms of treatment that other people just don't have? So anyway, I'll leave it there because that's the end. So thank you for hanging out with me, and I will talk to you guys the next time. See ya.